you have any questions from our guest, Dr. Fryer, on low back conditions, your sciatica, chronic lower back pain, what's going on there, what sort of treatment, give us a call. It's toll-free, 1-877-280-0650, or Vancouver area local call 604-280-0650. Now, Dr. Fryer, you've designed a number of models that are designed to help everybody from chiropractors to neurologists to better understand and visualize what's going on with that anatomy and what to do with it. How is this helping you in your assessment and diagnosis of patients? We'll get to the other question that I was posing before the break in just a moment. But I'm interested because people are going to go to your website, and I encourage them to go. It's Dr. Fryer, drfyer.ca, and take a look at the spinal diagnostics that he's got in there and the other models that are being used by neurologists. How has this helped you?
Well, quite simply, excuse me, is if you could break the spine down into a forward and a back compartment. So when patients usually injure themselves, it's often when they've been bending forward for prolonged periods of time or there's a sudden load change. What I found is very helpful is patients, when they understand that when you bend forward, you're not creating a stretch with the majority of the tissues, you're actually causing a squash. There's actually compression. And that usually sets the stage like, oh, wow, okay, I'm actually compressing things when I go to touch my toes. Because it's been taught in so many circles outside of chiropractic, in yoga facilities and Pilates, is that when you bend forward, you're stretching things. You're actually squashing. So that's the basic premise of where I start, and then I work from there.
Now, before we took the break, we were going to pose the question to you about what are the kind of feelings, pains, and issues that the person who's been 6 months on with their problem has. What do you recall from these patients as common to them? They've been waiting 6 months, it hasn't gotten better, and finally one day their family, friend, co-worker, or relative says, call Dr. Fryer and you need to see him for your lower back. What have these people been having for 6 months or more before they saw you?
Well, often they'll get symptoms after they sit for a period of time. And they don't necessarily always experience pain when they sit, but upon getting up, they have pain for the first, 10 steps or so, and then all of a sudden their back starts to loosen up a little bit. But that is an ongoing symptom that facilitates the degeneration process in there. So that's one thing. Pain after sitting. The other one is prolonged standing, like even in the kitchens. And when you stand, the spine actually loses height, and certain joints slide together. So prolonged standing. Or if people, if they have pain when they walk for over 35 minutes or so. These are all signs that it's disc-related, or the intervertebral disc is playing a big part in their symptoms.
So if you start to change the mechanical movement of the vertebrae above or below the disc, that sort of decreases the pressure and changes the symptoms.
Exactly. You want to increase the disc height, even if it's a little bit, even if it's a millimeter, it means the difference between symptoms and no symptoms.
Now, when you do these treatments, is it fair to say, because you just twigged me onto something about disc height, so when you do the treatment and it restores that mechanical functional movement of one bone related to the next, and you want to change the disc, is it fair to say that the net effect or the net result is decompressing that disc?
Yeah, absolutely.
So the whole issue of restoring disc height and disc health, if you will, it can be done a number of ways. Now, what sort of advice do you give to the patients in terms of what to expect from treatment? So walk me through in a few moments here, if you will, fairly briefly. A patient comes in for the first time. They express that they've got a problem in their lower back. It may be causing them some numbness or pain into their leg. Just walk our listeners through a very brief, typical exam that they would expect to get from a chiropractor.
Well, I take a careful history, and often in the history you get some clues on where the problem is. They say that 80% of the diagnosis in the history. So we listen very carefully to when it came on, how it came on, and that usually sets the stage for putting together a treatment plan. So active range of motion, like just watching the spine move and looking for glitches and where it hurts and where it doesn't hurt, that also begins to develop a treatment strategy on what we want to do to improve the tissues. So we're not only assessing the active range of motion, but at the same time we're always computing on what we need to do from a therapeutic standpoint to maximize the treatment efficacy. And of course, if there's signs and symptoms of tingling or numbness, we want to do a thorough assessment with the nervous system and make sure there's no neurological compromise or the nerves aren't being really squashed too much. And if there's any orthopedic tests to rule out whether it's hip or lower back, we make sure we do that as well.
So when you see your patient, and tell us what expectation do they have? Do you tell them that they need to rest for the next 2 days, and how long before they should start to feel a difference in their symptoms? I'm not asking how long before they're cured, but how long before they start to feel some change that says, okay, this wasn't as bad today as it was yesterday. How long does that take, and what advice do you give them for their lifestyle and behavior the first 2 days?
Yeah, that's a good question because, I have patients that come in with acute car accidents and they're not going to respond as quickly as I would like them because there's deep inflammation in the spine. So with those patients, it could sometimes take up to, like a week and a half to 2 weeks that's at the extreme, but start to see some improvement. But most often, after the first or second visit, they're going to start to feel some improvement in decreased stiffness, or they're going to be able to sleep a little better. And one of the things that I really advocate because of my research in the spine is that I recommend naps.
Naps?
They don't need
you mean
naps.
sleep?
To lie down. Yeah, we know that the environment when you're lying down on the disc is very similar to microgravity in space. And when you lie down and you can just decompress that spine just a little bit, it flushes in new fluids into the disc and increases the height a little bit. So, around 3 o'clock in the afternoon when you start to feel sleepy, well, I think it's the body's way of saying, okay, lie down and unload the spine a little bit. And so I encourage patients to actually take naps.
Naps. How does that go over with their spouse, their friends, or their employer?
Yeah, they got to figure that out themselves, I guess, eh? But
Oh.
I do have patients that actually just say, no, I got to lie down. Dr. Frere says I got to do it, so they lay down right in their, sometimes right in the office where they're working, and it works. It really helps them.
Now, how do you explain to a patient who comes in, and I've had this in presentations I've made, at times when I have to give talks or people I run into, or even on some of the programs, they say, Dr. Don, I don't have back pain. I have sciatica. What do you say to that person?
Yeah, exactly. Well, it's coming from your back. And I'll have some patients that, you treat them and then all of a sudden their back hurts. And they say, what did you do to me, doc? My back hurts. So I'll say, well, how's your leg? Well, the leg pain disappears. It's called centralization. So that's an indication that actually the inflammation is coming down. So, but we want to make sure, of course, that the leg pain is coming from the back. So we need to rule out, other things as well.
But I've often found it interesting. It's when people get up in the morning, and I said this to our previous two colleagues and experts, is that when the patient gets up in the morning, and in the case of men, when they lean forward to shave in the morning, or men and women, and they lean forward to brush their teeth in the morning, if they're experiencing a history of problems around the lower spine, fourth, fifth sacrum area, basically the bottom of their spine, the moment they go to lean forward first thing in the morning, it may hurt. They can't bend forward frequently. But throughout that entire experiences, as they're standing there looking in the mirror, they're feeling what they're feeling, the words, oh my God, there's pain in my fourth lumbar, there's pain in my fifth lumbar, that never occurs.
No.
They have the other symptoms. So it's always a challenge to try to get them to understand that they have a spine, there's 2 or more vertebrae involved, and the effect on the disc, the nerve, and their symptoms is always an ongoing process of education.
Yeah, exactly. And that morning stiffness, we know now in the literature, it's a sign of a degenerative disc most often. So it's a disc that's actually, over the course of the night, it's swelled up, which is fine. It takes on the fluid. But in the morning, the fluid kind of pushes through these little tiny fissures in the disc, and that's where the stiffness presents.
Now, when you in the treatment program that you and our colleagues have provided, in the majority of these cases, if it's a normal spine and spine related problem, these kinds of symptoms that are affecting the disc, they start to change within what, 2 or 3 office visits as a result of the treatments you're doing to those vertebrae?
Oh yeah, that's what I expect for sure. And if there aren't any outcomes, improvements within 2 or 3 office visits, then you got to change gears, in my opinion. So.
And we want to be stressing here, we didn't tell the patients that you're cured in 3 visits. It just means that the effect of the treatment should start to have some feeling that starts fairly quick.
Correct. Yes.
So, Dr. Fryer, before we sign off here, I'm also looking at your website, and it says here that you've had 4 personal North American speed skating championships?
Yes, I have. That was a long time ago.
Yeah, but still, kudos to you. That took a lot of effort, and if you didn't get enough congratulations before, we're trying to help you get that retroactively. And also 7 Canadian national championships?
Yes, that's true.
How come we don't see you in the BC Sports Hall of Fame?
I don't know. I guess I didn't make the cut.
Oh, well, maybe we'll pass the word that you did. Dr. Fryer, thanks for being so much on the program tonight. And if we have any emails from our listeners tonight on lower spine problems, we'll send them your way. And thanks for being one of our experts and coming on the radio tonight. We'll be in touch again.
Thanks for having me, Don.
Anytime. Bye-bye.
Bye.
So, Michelle, I hope we were able to give our listeners a sort of a walk down, not memory lane, but a walk down the spine or a walk up the spine, however they want to think about that. I mean, spine and spine-related problems, they continue to be a crisis in healthcare. 1/3 of all the office visits made Monday to Friday from the Atlantic to the Pacific. That's a crisis.
Yep, and 80% of us, I think it's even higher than that, but studies show that 80% of us will suffer a spine or spine-related condition at least some point within our lifetime, so from child to senior.
Well, if we can help the listeners understand that these are not diseases, illnesses, or aging processes, in most cases, they're physical events that have occurred, not unlike a sprained knee, ankle, wrist, toe, or finger. Those are bone joints too. It's just that the effect on 2 joints in the spine, it's the effect that is so radically different than what you experience in other bone joints. So if we can get people to understand that, number 1, you have a back, it's a bunch of bone joints, and there's lifestyle, there's prevention, there's wellness, but once in a while when things aren't working, there's your family chiropractor, and that can be highly effective.
That's right.
All right, now we did give everybody a pass tonight because they exercised so hard getting through the snow and the ice. We didn't make you do those exercises at 6:30 tonight, so we will remind you that these exercises and posture sheets, rather, are available at bcchiro.com/exercise. Now, how easy is that?
Yep, and when we're talking about exercises as well, if we refer back to our last guest, Dr. Fryer, if you go to his website, drfryer.ca, click on the blog section, and there's a chair care exercise video that'll show you how to unload your spine if you're sitting in an office all day. It's really effective. I use it quite a bit myself, actually.
Now, Michelle, next week we're going to a more serious topic that we've had on the air a while ago, traumatic brain injuries.
Yes, and it's been a very popular topic. It seems to hit more of the population than we estimate, that we underestimate, I guess, that so many people are affected by this issue. So yes, next week we'll be talking about traumatic brain injury, concussion, those types of things.
Underestimated and underdiagnosed. I'm Dr. Don Nixdorf, joined by Michelle in studio. Thanks for listening tonight, and thanks to our production team, Art Factora. He's going to be back on the Mirth Circuit, February 21st to 23rd at Comedy Mix, and to Dwayne, who's in the studio there too. So anyway, we hope you enjoy us next Monday at 6 p.m. here on AM 650 on our next serious topic. Until then, I'm Dr. Don, reminding you to make informed choices. It's your health. It's your life. Good night, Gary.